other topics. We are very fortunate to have a panel of wonderful professionals this afternoon, and I'm going to introduce them now in order of their presentation. Taja Ferguson. So Ms. Ferguson is the director of the Okanite Research Department at Valley Health System. She completed her undergraduate studies at Tennessee State University and her master's in public health from New York University. Prior to Valley, Ms. Ferguson worked at the Icahn School of Medicine at Mount Sinai in New York. We have Dr. Broussard. Dr. Broussard earned her medical degree at Case Western Reserve University School of Medicine. She completed her residency in internal medicine at Johns Hopkins Bayview Medical Center in Baltimore, Maryland. And then she did her fellowship at the Cleveland Clinic in gastroenterology. She is board certified in internal medicine and gastroenterology. Her practice is located in Emerson, New Jersey. Dr. Tia Welsh. Dr. Welsh is the chair of obstetrics and gynecology at Valley Medical Group and the Valley Hospital. She completed her undergraduate studies at the University of Virginia, followed by her medical degree at SUNY Brooklyn College of Medicine, my alma mater, but I digress. She did her residency also at SUNY Downstate. Dr. Welsh received her MPH at Independence University. She's board certified in obstetrics and gynecology, and she works at the Valley campus, both in Ramsey and Wayne site. Anita Sagogo Rodriguez. Anita is the social worker for the Population Health Department within our Valley Health System. She's a licensed social worker and obtained her bachelor's degree from Kane University in special education and her master's degree from Rutgers University. Her social work profession began in 2001, with the majority of her career being in direct client and patient care within that field. She's worked with several different populations, including mental health, addictions, developmental disabilities, home care, elderly, and with hospice. Jennifer Mcguigan Hill. Dr. Mcguigan is an internist in our Park Ridge location. Dr. Mcguigan received her medical degree from the University of Maryland School of Medicine and did her internship and residency at St. Vincent's Catholic Medical Center. She's board certified in internal medicine. Dr. Williams will be joining us a little bit later today. Dr. Williams is a cardiologist at Horizon Cardiology and a member of Caligo Care. Dr. Williams completed his undergraduate studies at Yale University, followed by his medical degree at George Washington University, residency and fellowship training at University of North Carolina, Chapel Hill. He's board certified in internal medicine and cardiology at nuclear cardiology, echocardiography, and cardiac CTA with a practice located in Ridgewood, New Jersey. So we hope to have nice dialogue today. We're going to have each of our presenters share some information to give us insight in how we take better care of ourselves. Ms. Ferguson.
Okay, thanks for having me, everyone. Can you hear me okay? All right, so I'm going to start by defining what a clinical trial is. For the purposes of today's talk, I'm going to use the word clinical trial and research interchangeably. So what is meant by a clinical trial? Clinical trials are research studies performed in people that are aimed at evaluating medical, surgical, and behavioral interventions. They are the primary way that researchers find out if a new treatment like a drug or diet or medical device like a pacemaker are safe and effective. So before we discuss disparities that exist in clinical trials, I want to briefly recap a study that happened that, in my opinion, laid the foundation of mistrust. And that study is the syphilis study in Alabama in the 1930s. And just a bit background, the syphilis study was conducted in Tuskegee in Macon County, Alabama. The study was funded by the federal government and aimed to study the long-term effects of the disease. The study recruited approximately 600 men, and lured them under the guise of medical care, food, transportation. And this was a very poor community. So having access to these things were very important. Unfortunately, these men and their families were victims, and the disease was left untreated, even though the researchers knew that penicillin would cure them. The study ended in the 1970s, and as a result, the National Research Act passed in 1974-75, and that mandated that all federally funded proposed research with human subjects be approved by institutional review board. And there are a lot of acronyms in research. So we call that the IRB. The IRB is usually a panel of people, doctors, laypersons, and what they do is they review research protocols to see if they're scientifically sound. And so that was mandated in the mid 70s. And so, as previously stated, this study laid the foundations for African Americans' continued distrust of the medical establishment, especially public health programs. It reinforced the views that the medical establishment, the federal government, they disregarded the lives of Black people. But with the foundation of mistrust has come lower enrollment numbers on clinical trials. And so Black people bear a disproportionate share of cancer burden in the US. They have the highest mortality rate and the shortest survival across race, ethnic groups for most cancers, and Black men have the highest cancer incidence rates. In oncology clinical trials, it the the foundation really is that clinical trials has helped find new treatments to save and improve lives. However, for the outcome of clinical trials to have validity, participants should represent the patients that will be using the medical products. And this is often just not the case. Racial and ethnic minorities are underrepresented in cancer clinical trials for a variety of reasons. And we already touched on one, right? So this is a concern because people of different ages and races and ethnicities may react differently to medical products. And according to the US Census, projections, more than half of the population in the US is expected to be non-Hispanic white by 2024. So there's a bit of good news. Recently, Congress approved the Clinical Treatment Act, which requires Medicaid to cover the routine clinical care costs of patients associated with participation in research. Since Medicaid serves a large portion of individuals from racial and ethnic minority groups, this legislation removes barriers for participation. So I just want to stop there for a second because it's a big deal. So the Clinical Treatment Act, it was enacted January 1 of 2022. So approximately 45 days ago, Medicaid patients who are on Medicaid can now be on clinical trials. Prior to 45 days ago, 80 million people did not have access to clinical trials, and they do today. So, big deal, something to celebrate. So the Valley Hospital is committed to serving and engaging our community, and that includes improving access to clinical trials. Recently, Valley was invited to participate in a national pilot study being conducted by the American Society of Clinical Oncology, stands for ASCO, and the Association of Community Cancer Centers, so we call that ACCC. The pilot study aimed to test self-assessment tools and an implicit bias training program focused on increasing trial participants. So this joint initiative was designed to identify and implement novel strategies and practical solutions to increase cancer treatment. So data collection for the pilot study, I would say it ended around the end of the year, December 2021, and the results of the study will probably be rolled out in the spring. But additionally, we received a grant a few months ago, and hopefully the funding will come through in the next 90 days. And the grant will focus on increasing access, building infrastructure and capacity so we have a more diverse population enrolled onto trials here at Valley. That's all I have. Thank you.
Thank you very much. We'll come back during our question and answer session to talk a little bit more about enrollment in clinical trials and people of color. Thank you very much, Ms. Ferguson.
Thank you.
Dr. Broussard.
Good afternoon, everyone. First, I'd like to thank Bergen Community College, Valley Hospital, Dr. Burgess, and Liz Lucas from Valley, all for inviting me to have this opportunity to speak during Black History Month. And the topic is so poignant and so relevant, healthcare disparities in the African American community. And I think it's a timely topic. It's something that needs to be discussed among everybody, but especially people of color need to know the disparities and what we can do about them potentially. So when we talk about, I just want to set the stage. When we talk about healthcare disparity or health disparities rather, health disparity refers to a higher burden of disease, injury, mortality experienced by one group of people. That's health disparity. Healthcare disparity refers to differences in access to healthcare in a particular group. And people of color experience both health disparities and healthcare disparities. Now, today, we're going to focus on health disparities, which involves many factors, not just race and ethnicity, which is what we're going to talk about today, but also socioeconomic status, gender, disability, and even geography. So there are a lot of things that make up health disparity, but today we're going to focus on race and ethnicity. So just for starters, there's large racial disparities that exist in health status between whites and minority racial ethnic groups. And that even is existent even when we take into account socioeconomic status and clinical factors and lifestyle and access to insurance. So those factors even exist even when we account for those modifications. But the mechanism for racial disparities in health, they're very complex. There's not a right or wrong answer. It's very multifactorial and incorporates many different things, including genetics. So we have no control over our genetics. Sometimes it's a socioeconomic status. We know that in areas where there's higher poverty in the Black community, they don't have, they're not as healthy, they don't have as much access to healthcare. Environmental factors can play a role. Cultural factors, how we think about health and our well-being and about doctors in general, our behavior, our lifestyle, having access to healthcare plays a role, not just having access that we have to healthcare, and most importantly, and very importantly, quality of healthcare. You may have access, but if quality is not up to par, then you're not going to get the best care. And in my field, I'm a gastroenterologist, so one of the most obvious areas of racial and ethnic disparities in my field is with the diagnosis and management of colon cancer, particularly in African Americans. And just to give you a background, colon cancer is the third most common cancer diagnosis worldwide, and it's the second most common cancer death worldwide. So it's a very common and it's a very lethal cancer. That's the bad news. The good news is that colon cancer is preventable and it's curable when it's caught early. And there are screening tests that can be done to save the most beneficial one is a colonoscopy. Now, can you guys hear me okay? Okay. So 90% of all cancers arise from these benign growths in the colon called polyps. And when we do a colonoscopy, we detect polyps and we remove them. So hence we prevent and sometimes even cure colon cancer. So it's a very treatable and preventable condition. Unfortunately, although the incidence of colon cancer has gone down over the past 10 to 20 years, that has not been as effective with people of color, African Americans, and people of color. There's still a higher incidence of colon cancer in the Black community. Probably the incidence is about 40% higher than other populations. There's a higher death rate. I would say 20 to 40% higher incidence of colon cancer in Black people, a 40% higher mortality rate, which is dying of colon cancer. When Black people get diagnosed with colon cancer, they are more likely to have advanced disease, which makes it more challenging to treat. And unfortunately, we're seeing a higher incidence of colon cancer in younger people, Blacks, Indigenous Americans, Hispanics, younger. And I'm not talking younger under the age of 50, I'm talking younger under the age of 40, 20, and even in their 20s, especially in the Hispanic population. So we're seeing much more morbidity and mortality in some of these other communities of color dealing with a preventable and curable disease. Now, part of the reason why there's such health disparity in this condition is that, well, it's multifactorial. Primarily, there's a low incidence of screening for colon cancer in people of color. Part of that has to do with access to being educated about the importance of screening, being educated about colon cancer and how it's preventable. There's some innate bias from physicians who may be not as likely to recommend a colonoscopy for a person of color because they think they don't want one, cultural bias. Maybe they're not educated about it. There are a lot of different reasons why, but these are things that are potentially treatable as far as educating our people and making them aware of the opportunities that exist to prevent such a common cancer. And I think one of the ways it hits home is when we think about the young actor Chadwick Bosman, who was in Black Panther. He was the main actor in Black Panther. He died of colon cancer at age 43. And that's and he was diagnosed at a later stage and he was dead by the age of 43. Colon cancer has a lower survival rate in African Americans, Indigenous Americans, and Alaskans. So all these things are potentially, need to be addressed, and I think can be addressed. We have to deal with some of our own cultural biases. A lot of times in the Black community, there is issues with not trusting physicians, not wanting to go to their doctor to get health care. There's some fear there. There's some health illiteracy that we as a community can educate and hopefully improve upon. I think there's some socioeconomic factors, sometimes based on our lifestyle, our diet, our what we consume in our body can make a difference. And we're also less likely to talk a little more openly about our family history. A lot of us don't know our family history. It's very hush-hush sometimes in the communities of color about what diseases family members have or not wanting to talk about it. But it's not just on the patient, it's also on the burden of the physician or the provider, because like I said, sometimes they don't recommend appropriate screening or offer screening to patients of color. They may not know about the less invasive way to screen for colon cancer. Even if a patient decides they don't want to have a colonoscopy, there's more than one way to screen for this disease. But there are some things that we can do as an individual. And I think part of the mitigation strategies to help prevent some of these issues are patient education. We have to be our own health advocate. We have to know our own health. We have to know about our family's health. We have to ask those questions about family history, and not just of cancer, but any chronic health condition. But our behavior plays a role too. There are modifiable behaviors that can reduce the risk of colon cancer. Diet plays a paramount role. Diets that are lower in fiber, higher in red meat, higher in processed meat, increase your risk for colon cancer. Obesity increases your risk for colon cancer. Alcohol, tobacco, physical inactivity, all these things can increase your risk for colon cancer. And these are things that we can modify as individuals. We need to know the warnings about problems that pertain to the colon. So educating oneself about the risk factors that warrant you going to see a doctor to get evaluated. And in my particular field, when I'm screening for colon cancer, when someone's seeing me, I ask them about any change in bowel pattern, any abdominal pain that's been persistent, any unintentional weight loss. Is there a family history of colon cancer? Are there any underlying diseases that might increase your risk for colon cancer, such as inflammatory bowel disease? But most importantly, even if we have none of those issues, screening is recommended for all people now at the age of 45. It used to be the age of 50. And for African Americans, because we have a higher mortality, they had recommended African Americans getting screened at age 45. But now medical societies are recommending everyone be screened at the age of 45, and even younger if there's a family history, strong family history. So screening without any symptoms, you should be screened at age 45, irregardless. So there are very proactive things we can do people to improve our health and reduce those health disparities so that we can live long, healthy, productive lives. It's not just about Black Lives Mattering, it's about Black health mattering too. So I think we need to all rise up to the occasion and do what we know to do personally and for our family to correct some of these disparities in my field. Thank you.
Thank you very much. We'll come back to, again, some of the habits that we can do to try to keep our bowel health intact. Dr. Welsh?
Thanks, Tracy. Good afternoon, everyone. I just wanted to introduce the subject of women's health. I think a lot of times when people look at OBGYNs, they think of birth and delivery, as opposed to obstetrics and gynecology, which are two very important things to women. In the GYN side, cervical cancer affects us, and the HPV vaccine is there. People in our ethnic group are very afraid of vaccines. But then on the other side, a lot of physicians don't push a lot of vaccines, depending on where you go. And, it's important to understand that we are not a monolith. Many African Americans are made up of a monolith of this country, and we all have diverse backgrounds. So it's important, one, to screen, as you just heard, screening for cervical cancer and getting your pap smears at regular intervals, screening for breast cancer, screening for colon cancer. And the HPV vaccine is a vaccine that has tremendously decreased the rate of cervical cancer in this country. But we're seeing it increase again because people are not getting their HPV vaccine, unfortunately. Fertility affects us as well. And many times it's from something preventable, unfortunately, such as STDs. The rate of STDs is on the rise. And unfortunately for women, once they have chlamydia and it goes untreated, that could totally affect your fertility by scarring your tubes. And not knowing that and not being treated could affect us for the rest of your life. But on the other side of fertility is women who are on the move and doing their thing and delaying fertility. We're not having children at the age of 20. We're not having children at the age of 25, and we're delaying it to 35 and older, which is already advanced maternal age, putting us at an increased risk group in the OB side. However, many women are not hearing about egg preservation. As we delay our fertility, it becomes increasingly harder. But no one is talking about, hey, at 25, if you don't think this is what you want now, we have life insurance, we have home insurance, we have car insurance. This is mostly like fertility baby insurance. Let's take your healthy eggs and save them for a rainy day when you want them. No one's talking about this because there's an assumption, unfortunately. There's an assumption when you walk in about cultural assumptions, that every cultural biases that everyone has. And getting over some of those cultural biases is necessary part of medical training for our field. And it's necessary for patients to feel comfortable. Fibroids, something that also affects women, especially Black women. It is really common for a woman to have pain and not mention it and think it's okay. And it's not okay. It's not okay to have heavy menstrual periods. It's not okay to have painful menstrual periods. It's not okay to have painful intercourse. Thinking that you're okay and you can handle it is not the way to go. you should be comfortable to talk to a provider. And you heard family history. Many of us don't know our family history. Your grandmother or your mother might have had stomach cancer. What does that mean? Was it stomach? Was it uterine? Was it pancreas? There's a lot of things in the stomach. Culturally, we don't talk about a lot of things. And it's important as we talk about family history, do we have these increased risk factors for fibroids? Do we have increased, history in our family of colon cancer, uterine cancer? Because some of those are genetic, just like breast cancer, that can be found with some simple genetic testing. How do we feel more comfortable in our community? There is an app called Health in Her Hue. I will put it out there. And this is an app that you can use and look up any type of physician that you want that is African-American, man or female. So whether it's an endocrinologist, whether it's a hematologist, whether it's an internist, you can look at your specialty in your state and you can find those that are in your area, someone that you may feel more comfortable speaking to about personal and health items. When it comes to obstetrics, you hear this term, morbidity and mortality. And a lot of people don't think, that's not me, I'm still here. Well, maybe not. Maternal mortality is defined as someone who succumbs during pregnancy or within the first 42 days after birth. But morbidity is probably more important than the mortality. And people don't realize what that actually means. Whether you needed a blood transfusion, whether you needed a hysterectomy during birth, whether you had a large laceration during a vaginal delivery, whether you got infected and needed IV antibiotics during delivery, that is considered morbidity. And more you're hearing of African-American women suffering and succumbing to morbidity, and not only that, mortality. Serena Williams, I think, was the poster of suffering, and that would be considered morbidity. Having pain and having no one listen to her, because culturally, it is thought that women, Black women, have a higher pain tolerance. I'm not sure where that came from, but it's not true. And people need to listen. And I'm the strongest advocate of never going to a physician's office or a hospital for that matter without an advocate. When you're going to a physician office, especially if you're going to get bad news, that you're only paying attention for that first minute, maybe. And everything else that provider is telling you is out the window, and you leave and have no idea what they said. Having someone advocate for you, listening with you, that's going to be of sound mind, is always what I'm going to advocate for. I always advocate for a birth partner. The same way you would want to be there for your family at the end of life, I think someone should be there at the beginning of life. And many people don't have that family member. Many people don't have that family member of sound mind. Maybe you use a doula. A doula is a support person that will support you during your birth process and ensure that your needs are being met. The other thing is African-American women are at increased risk of preeclampsia, which is a disorder of high blood pressure during pregnancy, of postpartum hemorrhage as well. All of these things, again, are associated with morbidity. We are not treated, African-American patients are not treated the same way when it comes to hypertension as our white counterparts. We're given different medications just because of our genetic makeup. Yet, when we have preeclampsia and we have high blood pressure, everybody gets treated the same. Does it work? Something that we really need to look into. But again, I think it is not enough for us to be afraid to seek a provider. I think there needs to be more trust with the medical system, understanding that most people will discuss the Tuskegee experiment. There are so many other examples out there of reasons why there's mistrust, whether it's Henrietta Lacks, an African-American woman whose cells are being used in research and she never even knew it. Whether it's Marion Sims, who performed all kinds of GYN surgeries on enslaved women without anesthesia. We are aware of the distrust in this country. However, it's time to be responsible, to find a provider that you trust. Just because you go to one doesn't mean you have to stick with that one. If you feel uncomfortable, find another. And I am here, and Valley is here to increase the cultural competencies and increase the way we reach out to the community.
Thank you very much, Dr. Welsh. Again, we have some questions in the area of women's health, so we'll be looking forward to hearing from you shortly. Ms. Ms. Seguello Rodriguez, I said it right the first time.
That's okay. Thank
Share
you.
some of your thoughts too.
Yes. Hi, good afternoon, everybody. And thank you for inviting me today to sit on the panel. So I'm the social worker for Valley at Population Health Department. And what I do is I offer telephonic case management to Valley Health System patients. And I provide community resources and supports over the phone. And I'm glad to sit in today because I was asked to discuss the importance of mental health and what some barriers may be to accessing mental health services and why this is important and how it can improve somebody's life and some disparities that may exist. I have some resources that will be coming up on the side in a few. Some disparities or some things that people, why they may resist or not be for accessing mental health is some people, it might be seen like as a weakness, like this preconceived notion that they're strong or they feel they could handle it on their own. Some maybe a lack of insurance or resources with that, or lack of community resources available to someone. So I've included a list of several places that offer both in Bergen County and in Passaic County for mental health resources. And if there's any additional questions, please feel free to ask at the end. Thank you.
We placed some of the resources that you had over in the chat column. So hopefully everybody can see that. We'll also try to put it in the Q&A box when we get a chance as well.
Okay.
Dr. Mcguigan?
Good afternoon, everyone. Thank you so much for having me and being on this panel. So I'm a primary care internal medicine physician, and I practice at Park Ridge, the Park Ridge location with Valley Hospital. And so I see a range of adult patients with a variety of medical conditions, but in particular, diabetes is a condition that's very, very common. And it's very common among even younger and younger age groups. And it's something that can be a very serious condition and have a wide range of symptoms on presentation. I had one young gentleman that came. He was a new patient, and he mentioned that, he drinks, a lot of water, and that was in response to my asking him how well he hydrates, and he just kept, perseverating over how much water he drinks. And so he also mentioned he has been really trying to be healthy, lost a lot of weight, but his exercise efforts really didn't match, how much weight he lost. And then I asked, are you able to quench your thirst with water? And he's paused and thought about it. And he actually said no. I mean, he was drinking gallons and gallons of water. We did blood work on him, and it showed that he was in fact diabetic. And this was, about 30-year-old gentleman. And so, it really kind of highlighted the importance of, getting routine medical care and, voicing your symptoms. Diabetes, it's a serious condition. It basically affects about 34 million people, which is like over 10% of the population. And there is definitely a disproportionate impact on Blacks, Hispanics, and Pacific Islanders, Asians. Roughly the prevalence is about 11% in non-Hispanic Blacks versus 7.5% in whites. And, it's something that's on a rise even in patients under the age of 30. Typically with diabetes, the body needs insulin to manage glucose, and glucose is very important to make the body function and run for energy. And what happens is when, insulin, either there's resistance or the body is not producing enough, you end up having a lot of glucose roaming through the bloodstream. And over time that can cause, serious disease on the heart, the vascular system. People can present with excessive thirst, excessive urination, unexplained weight gain or weight loss, fatigue, anxiety even, blurred vision. And these are things it's very important to just be aware of your body and your symptoms and not downplay them. And if you're experiencing any of these things, definitely seek care. And, when we talk about seeking care, and we talk about these disproportionate numbers among a minority population, you ask why, what are these barriers? And many of them have been mentioned. The trust in, medical community. Oftentimes people are experiencing these symptoms, they don't have anywhere to go. Their primary care is the emergency room. And the reality is, in an emergency room, care will vary, and care will vary based on what you look like. There are some people that will go in with the same set of symptoms. I actually even had a patient went in to the emergency room. It was out of town. Same set of symptoms, classic diabetes, not a single blood test run. And this person came in because it persisted, and the patient was diabetic. But what can happen is, Blacks, Hispanics, minorities in general, when they present to certain medical facilities, the level of importance, the level of significance of their presentation and what they're feeling, it's definitely measured differently. And that has to change. That really is a focal point, because that not only misses a diagnosis, but then it really enhances the mistrust. Because if I go to seek medical care somewhere and my concerns are not addressed, if I develop that symptom again or have that problem again, I'm not going to go. I'm going to neglect myself, because you're left with that thought pattern. No one cares. No one's going to listen. And I've had patients tell me this, and as a reason for the delay in care. So that has to stop. The stigma has to stop. The level of importance and the fact that this person matters, no matter what race or ethnicity they are, that has to be really, really honed in on. Diagnosis is basically, with blood work and symptoms, and there are, many treatment forms. One of the most important treatment measures and preventative measures, it's nutrition, really targeting the risk factors. So overweight, obesity, poor nutrition, lack of exercise, high blood pressure, these are all risk factors for diabetes. And the more that we aggressively target these from, yes, a primary care setting, but also an environmental and family setting, the better chance we'll have to decrease these numbers. You know, unfortunately, you know, one of the barriers, you know, and reasons why the numbers are high in the minority community is, you know, the availability of healthy foods, you know, the environment that plays into, you know, the environment and food choices, meaning higher fat rich foods, more carbohydrates, starches, white sugar products, the juices. You know, we don't think about the juices and the sodas. Those count. Those are really high in sugar, and oftentimes the primary mode of hydration for a lot of my patients is juice and soda. And so these are all risk factors for allowing the body to just get oversaturated and have these glucose levels elevated and turn into diabetes. So addressing the blood pressure, addressing the nutrition, exercise, addressing the weight, these are all very, very crucial steps to decreasing the incidence of diabetes, and really honing in on the trust. You know, just like Dr. Welsh said, just right on point. If you have the right to have proper medical care, you have the right to have excellent medical care. Know your self-worth, and if you are not getting that, then you move on to the next provider and you utilize those resources to find the provider that you deserve. And if anybody is telling you anything less than that, or their behavior is speaking to that, then you have to move on. Otherwise, we will continue to die at a higher rate from all these conditions that are absolutely treatable. And the morbidity, just like Dr. Welsh said, associated with these conditions, vision loss, losing a limb, heart attack, stroke, these are all preventable. And you have to be your own advocate. You have to have that community. You know, it takes a village to be there to support you, and it's doable. You know, the care is there. So really addressing these risk factors are key. And that's what I do, you know, in practice. And Valley is very committed to this as well. We have a wonderful set of, you know, endocrinologists. We have a diabetes care management group, and they are very aggressive with treating this disease and knocking it out the park. So that's what I do.
Thank you, Dr. Mcguigan. Our last speaker to provide some insight before we move to questions during this wonderful week of Valentine's Day is Valentine's Day week, is Dr. Williams, to share some information with us about our heart health. Dr. Williams.
Hello. Good afternoon. I'm a practicing cardiologist in the community. My office is in Ridgewood, but my primary hospital is Valley Hospital. And it certainly is an honor to be able to come and speak to all of you today. I have a personal stake in this. My brother, who's a couple of years younger than me, recently suddenly passed away. He had risk factors. He had high blood pressure, he had diabetes, he had overweight, and perhaps the unspoken risk factor was that he was a Black male. And unfortunately, the statistics in our country, for many reasons, shows that we are at a very high risk in this country. So I'm certainly passionate about this topic. I'm going to talk very briefly about cardiovascular disease in general, and then I want to spend a few minutes on hypertension. So what is cardiovascular disease? And you think about it, you may recognize it more in your friends and family or personal experience as someone who's had a heart attack, someone who's had a stroke, someone who's had problems with circulation in their legs, where they lose their limbs, feet. Those are the end results of heart disease or cardiovascular disease. Usually you can think about it as the buildup of fat, plaque, calcium in the artery wall progresses to the point that it ruptures like a volcano, clot forms, and you have these sudden events that can be very dramatic. So with that, it can lead to these kinds of things that we talk about. So when we say cardiovascular, if you hear that term, it can be coronary heart disease, heart attacks. It could be stroke or TIAs or cerebral vascular disease. High blood pressure, because the blood vessels change as it ages and comes stiffer and more different and resistant sometimes, and it can cause elevations in blood pressure. Certainly heart failure is a big topic. We won't talk about it today. And also peripheral diseases in the blood vessels in your legs and your arms can be factors that are related to cardiovascular disease. So here's the deal. The leading cause of death in our country still is cardiovascular disease. This is true for both men and women. We hear a lot, for example, in women about breast cancer as maybe leading. It is very important. We don't want to minimize any other disease, but I still want to stress to you the leading cause of these cardiovascular disease, including complications from high blood pressure. It's stated that cardiovascular disease is a leading cause of death in both the developed and developing countries, accounting for 30% of all deaths worldwide. This is as of 1999. And the belief is that this the statistics are even higher. So I'm gonna pause a minute because I want to talk. I think we have a few young people on this talk as well. There's an incredible opportunity. We need you. We need representation in leadership and research, medicine, sociology, anthropology, psychology, IT, entrepreneurial, whatever it takes. We're just part of the advocacy you hear here is not just for your family, but for our community. And you can do that by really stepping up if that's an interest, if that's a passion of yours. And it's not always has to be medicine. You can do it in other ways to really impact healthcare in our country. So I want you to just think that and be creative, because I'm sure a lot of you are. Is there a greater burden of cardiovascular disease with African Americans? Well, when you look at the statistics, just as you've heard from other speakers, here's the good news. Most Americans before COVID were living longer for all races. Here's the bad news. But the gap is huge still between people of color and other groups. In fact, the highest mortality rate and the shortest lifespan is for Black males. The highest survival rate and the lowest mortality rate in our country are for white females. And so that gap that exists is what we're talking about here, being empowered to sort of address that. So that African-American men are about 1.5 times more likely to die from coronary heart disease. African-American women about 30% more likely to die. Is there a greater burden of cardiovascular disease risk for factors that you can change in African-Americans? Well, let's talk about high blood pressure. Let's shift a little bit. So what is blood pressure? So blood pressure, if you've gone to the physician's office and had your blood pressure checked, you get 2 numbers. You get a top number and a bottom number. The top number represents the pressure that's generated when the heart contracts. The bottom number is the pressure that's generated when the heart relaxes. Both are important. If the pressure is too low, you're not going to survive. But if the pressure is too high, then you start having heart attacks, strokes, and bleeding and all kinds of craziness. So God has created us with a very incredible range that if you can keep it in that sweet spot, you can do awesome. So you should know your numbers. So ideally now, blood pressure, the top number, which is called systolic blood pressure, should be less than 130, and the bottom number should be less than 80. Now, it used to be, if you talk to your parents, it was less than 140 and less than 90. But what we've learned is that even in the lower ranges, there's a difference in outcome based on where your blood pressure rests. It kind of suggests, prior to all this industrialization and stuff we lived through in our country, when we were more hunter-gatherers and when we were out there on these farms out in other countries, eating more plants and more protein, our pressures were a lot lower, and this was less of an issue. So with that in mind, the other thing I will say is the target for African Americans, for Blacks in particular, is even lower. So for me and the Association of Black Cardiologists, we recommend a systolic blood pressure less than 120 and a diastolic pressure less than 80. That's crazy, right? But there's a lot of data to support that. So why would that be important? Because we know that for African Americans who have elevated blood pressure, they're 3 times more likely to die of a stroke, and they're 17 times more likely to have a renal failure. Some of that needs to be teased out. But we need you. We need people to come figure this out, because we know some of the statistics, but there's not a lot of studies or research. You've heard Taja talking about research. We need people to represent, to come and say, we want to figure this problem out. But it does exist. And the good news is that if we treat blood pressure aggressively, we may be able to still modify or alter that course. So what can you do to lower your cardiovascular risk? In this case, lower blood pressure, right? So number one, you've heard this from several of our speakers. You need to know your history. And it is true culturally at times for us, we don't talk a lot about our past. And it varies depending on where you're from and your background or whatever. But I always say knowledge is power. It's what you don't know that gets you in trouble, not what you know. When you know stuff, then you can begin to plan your life accordingly and know when you need to follow up to get certain things checked so you can live. But we don't have enough, just as an analogy, looking at my brother, we do not have enough Black men who are grandfathers, who are raising not only their grandkids, but their great-great-grandkids and their great-great-great-grandkids because of that wisdom that they've learned over the years, because they're gone. Know your history, know your family history. And then when you think about modifiable factors, in other words, there's some things we can't control, like we can't control our gender. Obviously, we can't control age. And if we have a family history or genetic hereditary issues, you want to know that, but some of that we can't modify. But here's what you can modify. You can address and know your numbers for your blood pressure and address it if it needs to be. If you smoke or know people who are smoking with high blood pressure, you stop smoking, the benefit, the bang for the buck is really dramatic and fairly quick in terms of reducing cardiovascular risk just by doing that. Addressing weight issues, right? And addressing other factors that may be important. Dealing with diet has been mentioned, and obviously we focus a lot. Unfortunately, we're often exposed to fats and carbs more than we need, really focusing more on protein and vegetable as the mainstay. So the final thing I wanted to share is a couple of things. There's been a couple of clinical studies over the years, more than a couple, have been a lot of publications. And through the American Heart Association, American College of Cardiology, we know that different types of exercise can lower blood pressure on a regular basis. And quite frankly, if you can do at least 30 minutes of some kind of cardio every day, that has a significant impact. I think for every hour, I forget the number now, for every hour that you exercise, I think you lower your mortality rate by an hour, something like that. There's a direct correlation with that. Minimizing the amount of alcohol, modest alcohol can help reduce risk. Then there's the weight management that we talked about. Basically, for every kilogram or every pound that you lose, roughly 1 to 2 points come off your blood pressure. There's something called the DASH diet, D-A-S-H. If you follow that diet, you get a very powerful drop in blood pressure. Now, here's the deal. Here's the deal. You can take that and modify it to fit your culture. Matter of fact, if you're interested in going into cooking and culinary, maybe you can help us out by creating these credible dishes that are actually healthy, that you can actually then use and do that. So there's many ways to impact this besides just becoming a physician. Dealing with low salt and also enhanced potassium intake for people who have normal kidneys can lower pressure. So the final thing I would say, Association of Black Cardiologists, we call it Simple 7, Simple 8. Here's what we recommend. Number one, be spiritual. There's something about prayer, meditation, and fellowship. Believe it or not, it's been studied, and it seems to have an impact on improving outcomes. Take charge of your blood pressure. Do you know your numbers? And also for you young people, do you know your numbers of your parents and your brothers and your sisters? Because you can be an advocate. Do you know your cholesterol numbers? Do you know your sugar numbers, as just talked about? Do Are you eating smart and exercising regularly? Which we can talk about if there's questions. Are you managing weight? Here's the deal. There's something called a BMI, right? This is basically basic metabolic index. It's the basic way to determine where, based on size, your height, and all, where your weight should be. And the target is 26. Do you know your BMI? And obviously, one of the struggles, do not smoke is the other one. And then number 8 is, which is a struggle for many of us, and understandably because of trust, is access your healthcare early and take your medication. So the deal with that is, I think someone, I think it was Dr. Welsh, you mentioned an app about identifying or following physicians of color. You see on this presentation, there are physicians of color. And then there are people who want to be your advocate. There's organizations like the Association of Black Cardiologists, the National Medical Association. There's different, you just got to do a little bit of Googling and research. You can actually find. And it doesn't matter. It doesn't even have to be a person of color. It has to be someone who you click with that is, is going to be your advocate. It could be the color blue. It doesn't really matter. It just matters that that person you trust because they are really going to be your advocate. Once you found that person, then you want to listen to them and let them help coach you and manage you and keeping you out of trouble. Thank you.
Thank you all. This was a wonderful wealth of information. There are questions that kind of cover for everybody. There's some questions that are individual. I'm going to start with this first question that kind of covers 2 similar topics. One was, how do you distinguish care that may be individualized versus care that may be stereotypical? And sort of the flip to that is, what websites do you as physicians look for your health information to make sure that you're getting the right solid information? Anyone can answer.
I'll jump in. So in terms of information, so there's something called American Heart Association. It's an organization that if you look it up or Google, they have what's called guidelines in driving care. And so if you look those guidelines up, there are things that are often used and tracked in hospitals and in offices as to optimal care for patients. Now, that's one option that you can look at and that physicians look at. But also patients can look at that. The other is my organization, Association of Black Cardiologists. I think it's abccardio.org. They have a lot of the same information and advocacy, and I'm sure that others on here could share with other groups, patient-friendly groups, and healthcare provider-friendly groups that you could actually look at to help guide you in terms of that. There's actually a lot of information out there. Part of the challenge is deciphering what is good information. So it still would be really helpful, regardless of what you see online, is to have a person you trust where you can say, I saw this or this was recommended. What do you think?
I think one thing that patients can do to kind of help decipher if their doctor is legitimate and they're being treated appropriately is to look at some doctor reviews. Sometimes there's a wealth of information online about a doctor and other patients' perspective of that doctor. If you get a doctor with consistently good reviews, that's a start at least. Maybe someone that you consider listening to or going to be evaluated for. But it's not easy. And so sometimes you have to go with your previous information, a patient referral, maybe a family member referred you to a doctor, look at online reviews. And sometimes you have to go with your own gut. If you go into the office and just something doesn't seem right, they seem like you're very short, very, not want to be bothered with your situation. They're kind of blowing you off, brushing you off, wanting to get you out the office before you even sit down. That's your answer right there too. So it's challenging, but you have to use the tools that are available. So if it's not referral from another friend or family member, you can use Google to look at doctors' reviews, and there's a lot of good wealth of information out there to help you discern. But ultimately, you got to go with your gut.
I think in addition to that, when a doctor starts to talk at you rather than talking with you, that's individualized care. Instead of assuming that you're in a heterosexual relationship, instead of assuming that you do not have a husband, instead of assuming and talking at you and asking you, what is your diet like? What do you eat? Instead of assuming that you eat fried chicken every day, assuming that you don't work out because you may be overweight, as opposed to asking what it is that you do, why it is that you don't do some of the healthier things and what are the roadblocks, that's individual care.
There's a question, and I want to kind of flip back to Taja about from the very beginning of the topic with clinical trials and history. Can you speak a bit more to what we can do to outreach to get more people of color into clinical trials? Clearly, as we know, and probably some of the people in the population, a lot of how we decide whether it's medicines or management comes from participation in research. So can you give some more input into how or why we should actively seek some of these things out?
That is a tough question. I look at it from the clinician standpoint, actually. There was a big research study at Duke University called Just Ask, and it was aimed at clinicians because they were the major roadblock for patients to be approached about a clinical trial. And so, one of the education kind of components of our grant is to educate clinicians to just ask the patient, and like Dr. Welsh said, not assume. From the patient side, I actually don't advocate enrollment. I advocate education because patients have to know that it's a research study. We don't know if the drug works. We don't know the outcomes. That's why we want you to participate. And so, when there's a person of color and I'm called to to talk to them, my goal is to have them make a decision based on the consent form. Make a decision based on the scientific merit and not from social media. So, I just advocate that they read the consent form, that they get reliable information, that they know what they're getting into, and they discuss the risks and the benefits.
Thank you. What always resonates with me is anything that has to do with mindfulness and meditation. I say I practice meditation. I'm always practicing and hoping to get better. Clearly in this COVID, post-COVID environment, it seems like everybody's anxiety has been higher. Can Anita or some other folks in the audience speak to anxiety reduction and what that does to our both physical as well as emotional health?
Sure. For anxiety reduction, there's a couple different things, definitely mindfulness, even like listening to something on an app such as Calm, or listening to like a sound of nature or some kind of like guided meditation. Those are a couple of my personal favorites. Aromatherapies, there's a big correlation between the calming of the mind and the body, and doctors could definitely speak to that regarding the blood pressure and everything else, how it just calms and reduces things. So those are a couple of, would be like my suggestions.
Yeah, definitely. I mean, there's been, obviously, for obvious reasons, everyone knows, it's significant uptick in the level of anxiety and disconnect and just vulnerability that a lot of people have been experiencing, definitely since COVID, and even, before that, and all of the stressors that, has come with it. And, in the Black community in particular, mental health has always been, stigmatized. In general, mental health has been stigmatized. And in the Black community, it was something that you just didn't talk about. But I am really, really pleased to see how much this mental health crisis really is being spoken about, and it's really being pushed to the forefront. And so, really talking about, acknowledging that, number one, what you're feeling, you are uncomfortable. I tell a lot of my patients, if what you're feeling is making you uncomfortable. You don't have to have the classic panic attack. You don't have to have the classic, jitteriness, but there could just be an overwhelming sense of feeling physically uncomfortable. That's something to talk about. If you feel that, before you were a very social person and now you more so are regressing and not necessarily wanting to call that friend or not really wanting to talk to that sibling, and you're feeling, that's something to talk about. The rates of suicide and it's on an all-time rise. The psychologists and psychiatrists and social workers, their patient panel is saturated. Talk to your doctor, talk to a friend, start talking about it. Things that definitely help all the time. Exercise, and it's not like you have to go to the gym for an hour or have a trainer or all this extra. Just literally pick 2 or 3 exercises in your home and just rotate through them 3 times over the course of 30 minutes. Just get your heart rate up. There's a benefit, like Dr. Williams said, to blood pressure. There's a huge benefit to how your body regulates glucose. Nutrition, if you choose to eat the right foods, don't let it have anything to do with what you're trying to achieve per se from a weight standpoint, but have everything to do with the fact that eating that plant-based, not having that fried food, not having that piece of chocolate is going to make you actually feel better, because then you fall into this positive feedback loop. Having a piece of vegetable or a baked chicken or something like that, it's going to make you feel better. It'll make you feel less tired. When you feel less tired, you feel better in general. So then you're able to kind of tackle that anxiety moment a little bit better. Meditation is key. A staple in the Black community has always been church and religion. Pray. Develop and make your belief system even stronger. And do all of those things. And that really has helped a tremendous number of my patients. Seek counseling. Seeing a counselor, psychiatrist, there's nothing wrong with that. So those are all the things that I tend to promote in my practice to address this mental health. Everything comes from a strong mind.
I think,
Oh, go on.
I just wanted to add really quickly, I think, especially since we're talking to a younger generation, if you're waking up in the morning and getting on social media, if you're getting on social media before you go to bed, you can change those 10, 20, 1 hour minutes to mindfulness, to meditation. And that social media itself creates a tremendous amount of anxiety, whether it is you want to look like the IG, Instagram models, whether it is someone bullying you, whether it is the Twitter fingers that, are bullying you on Twitter. To remove yourself from all of the noise. And a lot of the noise in our lives right now is on social media.
Since you're speaking, Dr. Welch, there was a question that I think you answered personally, but you could just answer it for the group. A question just came up about what women over 30 can do to try to decrease some of the pregnancy-related morbidities.
Yeah, I did answer, and that is what we've all been saying, diet and exercise. I never preach about diet and exercise, honestly, because saying that and expecting somebody to go out and run a mile is not what I'm looking for, and no one exactly knows what that means. That's when I take the 15 to 20 minutes to say, hey, what did you eat last night? For me, I let Google be my friend, to be honest with you. I have a piece of chicken. Diet, a lot of people think chicken and salad all day. That is not sustainable. No one's going to do that. And that's when people fall off. So what can you do with that lettuce? What can you do with that piece of chicken you have? I've already found 10 different recipes for a piece of chicken, to be honest with you, so that I am not getting into that rut. I don't eat a lot of pasta and rice, but what can I substitute it with? I can make, lasagna with zucchini noodles. Who knew? I can make macaroni and cheese instead of the macaroni. I could do cauliflower. Who knew? Cauliflower you can make taste like anything. There are so many things that you can Google so that you are eating a little healthier. When it comes to exercise, as they said, don't go to the gym. Don't run a mile. You could be watching your television and you could do your sit-ups and your lunges and your squats, and you can do all kinds of things. You don't have weights, go get the 2-gallon milk and fill it up with water. You have your own weights there. There's a lot of things that you can do within your home with no money. If it's a can of soup that you have, use the can of soup. Anything heavy, you can use as a weight. You can use your body weight. Stop with the negative habits, smoking. And I'm not stupid. When I ask people who smoke, do you smoke? Is it marijuana, tobacco, or both? Let's be honest with each other. There are some harmful effects to everything. Not only that, healthy relationships. One of the things with maternal morbidity is that we have a high incidence of unhealthy relationship. And if that is something that you're in, find yourself a way out. There's counseling, but maybe that's not the person you want to have children with. If you've already gotten an STD, if you've already been into the emergency room, if you've already a mother to someone you did not birth, that might not be the relationship for you. So if we start there, and taking care, and lastly is taking care of our chronic conditions. Not taking the high blood pressure medication once a week because you think you feel okay. Not with the asthmatics that need a pump every day, twice a day. Not with the diabetics that are already on insulin and you just want to eat another piece of cake. We have to take care of ourselves because honestly, the more obese we are, especially during pregnancy, the more difficult it is to look at the baby with a sonogram, the more incidence of abnormalities with fetuses because we couldn't see because you were obese, the more incidence of shoulder dystocia, the more incidence of bleeding. So there is a push that you don't have to be skinny and you can feel good in the skin you're in, yes, if you're healthy. That doesn't mean neglect the basic conditions that you do have.
Thank you. There's a question that came up. What initiatives does Valley have for the Black community to help reduce healthcare disparities? I'm going to start with the answer, then anybody can jump in. But we have programs like this. We try very hard to showcase who we have. We have ongoing social equity councils and other conversations that are happening internally. We have lots of different programs that are occurring that may be multicultural, not necessarily always targeted to a particular population, but we have a combination of things. We have a family education group program that will do breastfeeding. The doula program that Dr. Welsh mentioned a couple moments ago is actually a hospital-based doula program for people who need. So on the website, there are various things from the Valley Gym Health Center to multiple programs across multiple different specialties, in addition to the providers, whether we are talking about nursing, physicians, social work. There's a lot of different people that we partner with. So, and then I would also say for those that are in our audience, if you have other ideas or other initiatives that you would like to see Valley have, we're open to that as well. So this is a community of interaction, and we want to try to make sure that we hear what it is you want. So please let us know, because we recognize that the reduction of disparities is not a one-time thing or one size fits all. Any other last comments from the folks before we close for this afternoon? So I would like to thank, I'm just going to say it as I see it on my screen, Dr. Broussard, Anita Segovia Rodriguez, Dr. Mcguigan, Taja Ferguson, Dr. Welsh, Dr. Williams. Again, I'm going to thank the audience for attending this webinar. Thank you, Bergen Community College, for allowing Valley Hospital to participate during this, your annual Black History Month program, and that this year's emphasis was on health. While we celebrate Black History Month in February, we know that Black history is American history, and that the knowledge that we have of our history impacts our everyday living. During this webinar, we talked about how we're not a monolith. So we recognize we come from the whole diaspora. We're Caribbean, we're African, we're maybe right from Harlem or Hackensack. But we bring to all of our cultural influences, whether we're coming from a Spanish perspective, maybe some European perspectives. So we recognize that within what we call African-American, we're like a nice puzzle of all kinds of different things. We talked about modifying our behaviors and being active. And so hopefully those in the audience, I know for myself, I've picked up a couple of things that I'm gonna get on and try to modify and do a little bit better. Clearly, movement is the key, I think, to most longevity. So we're going to move, we're going to eat a little bit better to keep our GI systems well, to keep our mental health well. And so as we close, we wish you all a wonderful rest of the February. We're going to be going into March, and may we march on both socially as well as healthy in our emotional well-being as well. If there are any last comments from any of the audience or Dr. Williams, we can take this time. And I guess hearing none, we'll bid you good afternoon. Thank you all. And again, thank you for participating, both audience and panelists. Thank you.
Bye. Thank you.
Oh, last minute, remember, please fill out the surveys because there's a survey because we do look for your feedback. And this will be ultimately posted on one of the Valley websites. So again, thank you, thank you, thank you. Good health.
Have a good night.
Bye-bye.
Bye, guys. Thank you.
Bye.
Have a great night.